Thanks, Dr. Ladd. Okay, let me see if I can do my screen share here. Okay, are you guys able to see that okay?
Yes, that's perfect.
Okay, great. Okay, as Dr. Ladd mentioned, I am a PA. I've been working with Dr. Ladd in the HIV clinic since January when I joined OSU faculty. I've been practicing PA for almost 11 years. I spent about half the time working in primary care doing family medicine, really focused on women's health in that setting. And then most recently worked in breast surgery prior to joining OSU. And so my whole career, I've really been focused on women's health. And so I'm really excited to be able to provide this service to our women in the HIV clinic and to talk to you guys a little bit today about that. I have no disclosures. Oops. So let's talk about learning objectives for today. We're going to just talk about some screening recommendations for women with HIV, talk about some preconception counseling recommendations, contraceptive options, and pregnancy and postpartum considerations. And then also just learning to recognize some of the different dynamics of providing care to women with HIV. And so I just thought I'd talk about some numbers to start with. In 2019, across the world, close to 50% of all new HIV cases were in women. And in the United States in 2018, about 19% of all new HIV cases were in women. And that, as Dr. Ladd said, really correlates to our patient population in our clinic. And so currently in the United States, about a quarter of people living with HIV are women. This is some data from the CDC. This is, again, in 2018. This is incidence of HIV in females of all races and ethnicities, ages 13 years and older. There were about 7,100 new cases of HIV in women in 2018. And about 85% of those were due to heterosexual contact, and about 15% were due to IV drug use. This slide shows same parameters, but this is talking about the prevalence of HIV. And, you know, as you can see, people with HIV, women included, they're living longer. We have great drugs now. And so people are really living to their normal life expectancy almost. And so, you know, the greatest prevalence of women is in that 55 and older age group. And so this just means we need to be as vigilant as possible about practicing good preventative medicine for these patients. And so let's talk about some screening recommendations for women with HIV. We'll run through some cancer screening recommendations and then talk about osteoporosis. And my screen keeps, sorry, my screen keeps like going on its own. Let's see. Okay, so cervical cancer screening we'll talk about first. Cervical cancer is by far and large the most common cancer in women with HIV. You know, invasive cervical cancer in women with HIV is actually an AIDS-defining illness. And so we want to be very mindful of this and talk about screening our women on a regular basis. So let's talk about, you know, cervical cancer. Again, in women with HIV, they're at about a 10 times greater risk of having abnormal cervical cytology. Even when they're virally suppressed, they're at an increased risk. And they're also at an increased risk of contracting HPV. And as most of us are probably aware, HPV is the most common cause of cervical cancer across the board in women. As some of us may know too, there is a vaccine for HPV. It's Gardasil. Gardasil is approved for women with HIV. At any CD4 count, you can give it, but it's only approved in women with HIV 26 years of age or younger. And so while it is approved for people up to the age of 45, it's really not been shown to be effective in women with, or people with HIV, excuse me, under the, or over the age of 26. And so we don't recommend that. If I can, this thing is very sensitive. See if I can make this work right. There we go. And so I'm talking about the guidelines. And so these are going by the DHHS guidelines. And it really just breaks it down, just like the general population, by age group. And so talking about our women with HIV under the age of 30, we want to start screening, you know, within 1 year of onset of sexual activity, no later than age 21. We want to have a pap smear at an initial HIV diagnosis. And if that pap smear is normal, then we can repeat that in a year. There have been some experts, or still are some experts, that say repeat the pap in 6 months after initial HIV diagnosis, even if you get a normal pap. But that is not, as of right now, consensus guidelines. In this age group, if you have 3 consecutive PAPs, then they can move to every 3 years screening. Oh, I just did it again, sorry. And then co-testing. So co-testing is cytology plus HPV testing. And just like in the general PAP guidelines, this is not recommended to do in this age group. And so we want to order with reflex testing only. In our women that are 30 years of age or older, same principle, we want to do PAP at initial diagnosis of HIV and then once a year. For this age group though, you can do a PAP only, or you can do a PAP and co-testing with HPV. If you have a patient that has a normal PAP, negative HPV, then you actually can opt for every 3 years on your screening. That's a little bit different than the general PAP guidelines. They can actually go every 5 years. And then if you have a normal PAP only, then you again want to do the same as you would for your women under the age of 30 and repeat that annually until you get 3 consecutive normals. Where it's very different is our women over the age of 65. And so general PAP guidelines recommend stopping PAP smears in this age group. This is not the case in our women with HIV, so we want to continue to recommend screening above the age of 65 in our women with HIV. I threw this slide up there. This is an app. Some of you may already use this app. It's a really helpful app put out by the ASCCP. I do use it. It's not as helpful in our women with HIV just because the guidelines are pretty cut and dry on what to do with follow-up for these women. But it has some really nice algorithms in place that you can put in, you know, what their cytology is and what's their HPV status, and it helps you to know how to do follow-up for these women. Essentially, any woman that has HIV that has positive cytology, so with ASCUS, starting with ASCUS, so that's atypical squamous cells of uncertain significance, and they have a positive HPV test, regardless of their age, they need to be referred for a colposcopy. And so that is different than the general PAP guidelines. If you have a woman that has cytology that has ASCUS, but they have a negative HPV, it is actually appropriate to repeat that PAP in 6 to 12 months. You have to be mindful on your repeat PAP though, if they do come back and either have positive cytology, either with ASCUS again or something higher, or even if they have normal cytology and they have a positive HPV on that repeat PAP, then they need to be referred for colposcopy as well. So what about our women that have had total hysterectomies? Guidelines are a little bit murky on this, but if they've had a hysterectomy for a completely benign indication, and so you know, you have a woman that has had a hysterectomy, they had heavy periods, they opted to have a hysterectomy, technically you could stop pap smears, so not recommending vaginal pap smears for these women. If they've had a hysterectomy though for cervical intraepithelial neoplasia or above, they need continued annual vaginal paps. And if they have had an unknown reason for hysterectomy, which honestly, this is the majority of patients, they don't know entirely what the indication was for their hysterectomy, then we want to go ahead and continue those annual vaginal paps. I came across kind of an interesting study on this topic. It was a study published in 2016, and it was a retrospective study of about 238 women between 2000 and 2015 that had they have a history of HIV. they'd had a hysterectomy and they had had no history of abnormal PAPs. And so out of this small cohort of 238 women, about 73 women, so about 31%, had abnormal findings on their vaginal Pap smears. And they went on to have biopsies done. Of those that had biopsies, 28% had normal vaginal biopsies, but the rest of them actually had some vaginal intraepithelial neoplasia. There wasn't any incidence of invasive vaginal cancer found, but this does beg the question that we should, maybe think about just continuing annual vaginal PAPs despite our patients that have had hysterectomies for benign reasons. Again, small cohort of patients, a retrospective study, but it's just something to keep in mind. And so other cancer screenings we want to talk about, and I threw this slide up here just mainly so we don't forget about these things. There's really not any significant increased risk for breast, colon, and lung cancer. There may be just a slight increased risk of colon cancer, but it's really not significant enough to recommend different guidelines. So we want to just follow the regular guidelines for this. I apologize, my slides keep jumping around. We'll move to osteoporosis. We know that people with HIV, women specifically, have an increased risk of osteoporosis, really due to several factors. And so we have to think about traditional risk factors, weight, smoking, hormone status, and then we think about, the pathophysiology of HIV. It causes increased inflammation. It can cause altered bone metabolism. And then certainly some of the HIV medications can cause osteoporosis. We know that women with HIV tend to go through menopause at an earlier age. And so we want to follow the guideline that really any woman that's postmenopausal, we want to go ahead and order a DEXA scan. And it really follows just the general guidelines as far as frequency. And so, every 1 to 2 years, just depending on what the results were of that. And then something else to mention would be when you're calculating a FRAC score, you can actually check that secondary osteoporosis box, and that will increase the risk just a little bit based on having HIV, based on being on some medications, maybe certain HIV drugs that increase the risk, although it really still may underestimate their actual 10-year risk of an osteoporotic fracture. Okay, so we'll shift gears a little bit, talk about women with HIV of childbearing age. Any of you women that have been pregnant, you understand what this picture means. I felt like this when I was pregnant with my daughter, so it's not all it's cracked up to be all the time, but anyway. We'll talk about women of childbearing age as far as preconception counseling. And so, we have these women, we want to talk to them, really every time that they come in. We want to find out what their desires are. Are they thinking about getting pregnant in the near future? Are they actively trying to get pregnant? Or are they not interested in pregnancy at all? And so we want to find out where they're at. For women that are thinking about getting pregnant, then we want to make sure that they are on their regimen, and they're compliant with that regimen. And we want to make sure it's an appropriate regimen if they were to get pregnant. We also want to counsel them on staying undetectable. So having an undetectable viral load and really having 2 undetectable viral loads at least 3 months apart documented. We want to recommend that they have condomless intercourse only during ovulation. And we also want to make sure that they're up to date on their sexually transmitted infection screening. When we're thinking about counseling the women, we also want to think about their partner status as well. And so we want to make sure, if their partner is also HIV positive, we also want to talk with them about their partner meeting these same stipulations as well. And really want to stress, the end game of all of this counseling and these recommendations is if they were to become pregnant, we want to reduce the perinatal transmission risk as much as possible. So then we have a woman that they don't want to be pregnant. They have no desire to get pregnant. So what can we talk to them about? We want to talk about contraception, obviously. Condoms obviously are recommended. They prevent pregnancy, they prevent sexually transmitted infections, but we also want to talk about additional forms of contraception. So as some of you may know, there are lots and lots of contraceptive options out there. There's pills, there's about 1 million formulations of pills, there's injections, there's implants, IUDs, there's others. And so the big takeaway with this is all forms of birth control can be used in women with HIV, with just a few caveats. And so IUDs, so copper IUDs, hormonal IUDs like Mirena, these can be used universally with no restrictions. And so it doesn't matter what regimen that they're taking, it is safe to do an IUD in these women. We do want to be careful though with some drug-drug interactions with some of the other forms of birth control, specifically if they're on a regimen that contains a non-nucleoside or some of the protease inhibitor regimens. Some of these can either decrease or increase the efficacy of the contraceptive. And so we want to just be careful when we're prescribing a contraceptive option to these women that we're double checking to make sure that there's no interaction. We don't obviously want to give a woman a false sense of security and place her on a contraceptive option that may not be as close to 100% as effective if she's on a medication that could decrease that. So I put the Liverpool HIV drug database website link here. I use this a lot. I also consult with Dr. Connell. She probably gets tired of me asking her for drug-drug interactions, but it's something that I want to be 100% sure, specifically with anything, but specifically with this. And so this is really nice. You can put in whatever, birth control pill or Nexplanon or whatever you want to use in this, put the regimen in, and it will tell you if there's any interactions. And so what about our women that become pregnant? And so you have a pregnant woman now with HIV. Again, you want to make sure that they are compliant with their regimen. You want to make sure that they are on a regimen that is okay with pregnancy, which really the guidelines say, if you have a woman that is on a regimen, they're undetectable, they tolerate it well, really we just want to leave them on whatever regimen that they're taking. There is the study with dolutegravir that has shown just a small risk of neural tube defects. However, the neural tube closes early on in pregnancy, early on with the fetus. And so a lot of times, the woman gets to you, they may be already past that time. And so if they're on dolutegravir and they're tolerating it, then the recommendation would be to go ahead and leave them on that medication. That is something to consider though for your women that are considering pregnancy. You definitely want to have that discussion with them on risks and benefits of that medication. And then you want to make sure that you're following them frequently during pregnancy. So we follow them monthly to check that viral load, make sure that they're staying compliant with their medicine, and making sure that their viral load stays undetectable. There are some regimens that later on as you get in pregnancy, second and third trimesters, just really because of the physiological changes that happen during pregnancy, can decrease the pharmacokinetics of some of the drugs. And so we just want to make sure and monitor the viral load frequently, and then make adjustments if we need to by either increasing the dosage or potentially changing the regimen. And then so now they've had the baby, they're postpartum, and so I threw in just a couple of points here. We want to really immediately talk to them about contraception once they've had the baby. So what are they going to do to prevent another pregnancy? We're going to counsel them to not breastfeed, so we don't recommend breastfeeding in our women with HIV. And then also postpartum depression. And so, that's something obviously that we screen all postpartum women for, but it's really important in this patient population because they're at an increased risk of postpartum depression, and that can really affect, their adherence to their regimen. And so making sure to really ask about that. Okay, and then lastly, just talking about just some different dynamics of providing care to women and our women with HIV. You know, communication and sensitivity go a long way with women. Like I said, I have really focused on women's healthcare for my whole career. I've seen women in all kinds of different settings with different scenarios, all kinds of different patient populations. And really, there's a common denominator. Women appreciate communication, we appreciate sensitivity, we appreciate empathy. And so that really can go a long way when you're talking to women, especially women with HIV. You know, they are at an increased risk. There's an increased incidence of PTSD and trauma in this patient population. I found a study that was a meta-analysis that was done looking at 6,000 women, and about 30% of them reported PTSD. So that's a really significant number. And so it's just something we need to be mindful of and need to practice good communication with them. Always considering socioeconomic factors or issues. You know, women often, they're the primary caregiver for their children. And so that can present as a barrier to care. You know, they may not have anybody to watch their kids to make it to their appointment. They may have other barriers to care, lack of transportation, lack of insurance, and then just increased stigma, not just with HIV alone, but being a woman with HIV. And so that can decrease their linkage to or retention to care. This was a really powerful graphic, I thought, talking about intimate partner violence specifically. And so if you look at this graphic, the top is among all US women that were surveyed. And they had there was about a 3.6 out of 10 rate for experiencing intimate partner violence, which is really scary and concerning. And then if you look at the HIV women in the United States, it jumps to 5.5 out of 10. That is a really alarming statistic. You know, women may be less likely to disclose their status. They may be less likely to use condoms just for fear of repercussions. Just, you know, in clinic, a few weeks ago, I had a patient and she wasn't using condoms. She wasn't on birth control. She didn't desire pregnancy, but she was so terrified to talk with her boyfriend about her being on birth control or them using condoms because she said he would beat me up if I asked for those things. And so this is really a concerning statistic, specifically in women with HIV. And so because of this, we are now implementing a screening tool called the eHITS questionnaire. It's a really simple 5-question tool. It uses a Likert scale of 1 to 5, and it's to screen for intimate partner violence. Anything above or 7 or above, I believe, is a positive result. And so we're working to try to screen and try to identify some of these women. And I've talked with one of our counselors. Luckily, we have that in-house. And if we identify these women, we're going to have the counselor talk with them that very day that they're in the clinic and help guide them to some resources, help set up some follow-up counseling appointments. And just try to help these women. So I'm excited to see kind of how this pans out and if we can really make an impact and help some of these women. And I think that's it. Yeah, so there's my references. Thanks for letting me talk about this today. I love talking about women's healthcare, and I'm happy to answer any questions. Let me stop